Well, hello all. Welcome to our first ever dockside chat for the Medical Evaluation Laboratory. My name is Steve Parenti. I'm an Associate Dean at the Carlson School of Management for the Carlson Global Institute and a professor in the Finance Department specializing in health economics. I am one of the two co-hosts of the chat series. As you notice, we've moved from fireside to dockside because it is summer. And I'm pleased to have a conversation today with Professor Chuck Phelps from the University of Rochester, a longtime friend and mentor, and who has actually, we both have written a book about the future of health policy, and we thought it'd be great to discuss some of the options, given that several of them actually got a little bit underway in the more recent or two administrations. So that's part of what we're doing. Chuck has his PhD from the University of Illinois, his bachelor's, University of Chicago. Wow, really, pardon me, Chuck. And this, if I get this one right, and your bachelor's in math from Pomona College. I think I got that right. So, and basically was provost of the University of Rochester for a long time. He has a very long CV. He's a member of the National Academy of Medicine, and we want to keep the chat to our conversational, so we'll introduce more about us as we go along. Moderating this is Brianna Mayer, who is one of our star alumnus from the Medical Evaluation Laboratory. She took it when it was just a test course, and also is one of the pioneering students, one might say, experimenters, when we did took the evaluation lab overseas in Shanghai, and then later to Stockholm. And so I'm gonna turn this to Brianna. She's an expert now in the pharmaceutical industry and also one of our best and longest serving instructor for our pharmaceutical class that in the Medical Industry Leadership Institute. Brianna, please take it away.
Great, thanks, Steve. Really appreciate the opportunity to talk with both Steve and Chuck today. And we want to make this interactive with all the folks on the line. So please, as we go through the discussion today, please feel free to chat the questions that you would like to ask. For at least the first 30 minutes here, we would appreciate you chatting in the questions. And then once we go off record for the second half hour, we may be able to have folks come off mute and ask questions directly. So as Steve mentioned, in large part today, we're talking about the economics of US healthcare policy. So great cover, by the way, great title. This is a book that Steve and Chuck published in 2017 and also presented to multiple government sectors in 2018. And so we'll be talking about this book and as well as other current topics in health policy. And just as we kind of get this kicked off, I wanted to start with some of the proposals that you have mentioned within the book. You mentioned some really novel and economically robust proposals that I think the group on the line would be interested in hearing more about. So Steve, do you want to maybe talk about the top 3 proposals that you think should be implemented today? And then, you know, definitely include any proposals from the book that have already been implemented.
Sure. So I would say that probably if you look at the book, probably it leads with the proposal that still is a major objective, which is to deal with the tax exclusion for private health insurance, which is, Chuck's giving me a yes on this, or at least we're in agreement. So basically, it's the largest tax subsidy that basically the U.S. economy has, $260 billion a year and counting. Basically, it subsidizes essentially the overuse of health insurance. Our proposal is to essentially eliminate that, but basically return it in as an across the board tax cut for the income, basically all across all income levels. And actually, if you go through the book, one of the things we point out is that the current tax as it's currently structured is highly regressive. And actually, if you want to be, even if you want to play progressive politics, basically saying our proposal is probably one of the most progressive there would be to correct some of the distortion to go on the market. Second idea, and it kind of relates to the talk of a first or last stop of consumer-driven health plans, is that we need to have more price transparency in the market. That's something that the Trump administration actually did quite a bit to unleash, basically have prices be published and put out. And then a third area that actually was an accomplishment, I believe, was to actually rebuild or redo consumer-driven health plans. One of the biggest concerns people had about high deductible health plans was that if you have a major chronic condition like diabetes, you don't, you're not going to get anything for servicing for, say, insulin and other things. It turns out there was an IRS guidance that was put out in 2019 that actually does allow for health plans to now actually offer insulin and a whole set of stuff for different chronic conditions, depression, asthma, for essentially for free if those plans, employers in particular with those plans choose to do that. And last we checked, actually, there was a statistic came back, and I can put it out later. Basically showing about 40% of employers are now implementing that design in 1 year alone. That's a faster take-up rate than we actually forecast. Those would be my top three. Chuck?
Well, first of all, for the yachts behind this, since we're dockside, I think that's Steve's boat behind him. This is not my boat behind me. We're in a fireside chat that Franklin Delano Roosevelt spawned. Except at Somerset, it's a dockside chat. The boat behind me is a picture of the USS Sequoia, which was FDR's personal yacht. I wouldn't mind going out on it, but I can't afford to keep it. So first, I'll just reiterate, I concur with Steve that by far the most important thing to do to improve our healthcare system is to get rid of the tax subsidy for employer-paid health insurance. It distorts everything, and it's not just that it increases the demand for health insurance through that employer base, but it also squeezes out a lot of sort of small group and non-group markets by making it infeasible to compete in those areas. And that's true even with marketplaces that were set up under the Affordable Care Act. And if you gave people the equivalent cash by giving them, essentially turning it back to them in cash, which is what would happen instead of continuing to pay, just give them insurance only, a lot of companies would still keep providing the insurance. It's just that to be treated differently mentally by the people on the receiving end. But they'd also have the option of taking that extra money and going out and buying different plans. And you see plans springing up as we have all over the place in Germany and Japan and all over Europe that are sponsored by unions, by PTAs, by church groups, but you can't imagine the variety of plans that crop up. And that would just introduce a lot of competition in the health plans that simply is squeezed out with the current system. So that's an important, I think the most important part about this. The side benefit that our proposal, returning the money to the economy, is a permanent economic stimulus is secondary to the primary economic concern, okay? The next thing I would do, aligned with Steve's notion about price transparency, the other thing that I think it's really important, and I'll give Steve a lot of credit for devising the mechanisms to do this in the book, is to give people access to their own medical records. And I just think that's extraordinarily important. And, we're seeing that more and more now. I'm now in several large healthcare systems, one from UC San Francisco, and now that I've moved back to Rochester at University of Rochester Medical Center, and they have my chart, and I can go online and see a ton of stuff in the medical record now, and I think that's a huge step forward. There's still a lot of limitations on that, and I'm not quite sure how the best way to go about it is, but having information in people's hands about what's been done to them, what are the lab results, so they can talk to others. What would happen when you have this is that there'd be a completely independent market spring up, just like we have markets for financial advisors. And in fact, this whole thing kind of follows the financial services markets, if you think about it. But, I've got a really terrific financial advisor here. He doesn't peddle stocks or bonds or insurance policies. He just helps me steer through that morass. And I can easily envision the same sort of a market emerging in healthcare to help people decide which service they needed and which is most cost effective. But none of that makes any sense until you get rid of and get rid of the tax subsidy, and you'll have what I strongly believe will be an enormous stampede towards high deductible health plans. I just think that's there's just no ambiguity about that outcome to me. I think it's almost certain. And with that comes the message that Steve gave, that in order to do this, we really have to have secondary prevention built in, as bypassing the high deductible plan, so that people with diabetes, with asthma, with COPD, all these things where we know we have very, very effective, low cost per quality adjusted healthcare outcome. We've got very effective treatments, and we just want to make sure that people do those right away. The third one I'd add is a personal pet peeve. And I'll give you a personal anecdote with this, and that is the mechanisms that lead to these absurd prices that you get posted from hospitals and doctors. And I just had a month of treatment in preparation for a low back surgery I had. The charges billed to my insurance plan were $35,000. Ha! You gotta be joking me. The approved charges were about $3,500, maybe $4,000. It's about 10 or 12% of the billed charges. And of that, of course, my insurance plan paid much. So I ended up with a bill of $350 for this $35,000. That's the way it ought to work. But these absurd billed charges are an artifact of the tax law, so that the hospitals can write off these extraordinarily large charitable services at grotesquely inflated prices. And so you can fix that just by having the IRS say, hospitals can deduct charitable services at the Medicare rate. You'd see these ridiculous bill charges go away. That's probably not central to the policy world, but it's certainly a pet peeve of mine.
So Chuck, you mentioned a good point. I don't think there's anything more frustrating than when you go to the doctor and you're looking for answers, and you end up, debriefing the doctor on your condition and your own diagnosis versus, getting what most patients would like, which is the doctor debriefing them on their diagnosis and next steps they need to take and their past history. So I know you mentioned an app that you're using now in order to access your own healthcare, charts and files. What do you think we could do to make access available across healthcare systems so that people could carry their medical records with them and not kind of have that barrier when they go across systems?
That's really important. The proposal in the book is basically to have a trusted third-party provider stage all those medical records. The way that works right now, basically in the era of paper records, is your primary care physician is the closest proxy we have to that. So every time you go to see a specialist, your primary care doctor, if things are working right, gets at least a summary report of what happened to you, that the specialist did and concluded and recommended and all that. But that doesn't pass along the lab results. It doesn't pass along the actual images from the MRIs or the CT scans or whatever. And so my being able to identify a trusted third party, and they'll spring up there. Anybody in the digital world now, the big names you can think of can do this, and many hundreds of others will spring up. And then I can designate people that can put stuff into that, and people who can read the data in there, including my personal healthcare advisor that I want. But that would combine the data in a way that I don't think can go on, really be complete otherwise. Some of the hospitals that use the same platform have now linked these together. So for example, the two hospitals here in Rochester that I use, Strong Memorial Hospital of the University and the competing plan, the Rochester General Hospital, Rochester Regional Health, they actually share the same physical network. My chart, as does UC San Francisco, where I was getting treated for my, most recently my prostate cancer out in California before I moved. They all have the same system, so there's a lot of transparency there, but it's just pure luck that they all are on the same physical system. So we need to find ways, and I don't want to have one single system doing that. Would be a monopoly, and Steve and I don't like monopolies, but I do I do think the coordination across these can be greatly smoothed over, and maybe there's ways to do it easier than having to trust a third party that we wrote about in our book. But it's really important because that, combined with price transparency, puts the consumer in the driver's seat, and that's the goal here.
Absolutely.
I just want to reiterate, to be an informed consumer, though, you have to have the consumer able to have a guiding physician that doesn't have a personal financial interest in the treatments. That's one of the real defects of our healthcare system, is doctors get paid in hospitals on volume. And so when a doctor advises me that I need this procedure or that, there's a financial interest there lurking in the background. And if I have a third-party advisor that has no interest, just like my financial advisor doesn't have any interest in which insurance policy or which stock I buy, that's the ideal to me.
Yeah. Okay, thanks, Chuck. So your book also discusses some specific improvements relative to Medicare and Medicaid. So when we think about that population, which improvements do you think could make the biggest impact for those folks?
Well, I'll start with one. Again, it's a pet peeve that arose from my own personal experience, but I think it's really important. And that is the treatment of Medicare Advantage. Medicare Advantage is an incredibly good idea. It basically turns Medicare into a voucher system. I can take my Medicare eligibility and I can go buy a health plan with it, and I can choose among competing plans. And they offer, different sets of services. Some of them are lower cost and they have more stringent cost control and prior authorization rules. Others are more expensive and looser on those. And I got that choice. But when you come down to those Medicare Advantage plans, there's a couple of things that are got to be fixed. The first is they have to offer all the services that Medicare offers by law. And Medicare is probably offering some services that are really dumb. They're very expensive for the value you're getting out of them. But Medicare by law is prohibited from using costs as a consideration in choosing treatments that they offer. And so that mistake is passed on to the Medicare Advantage plans. That's not true in Part D pharmaceuticals. Part D pharmaceuticals can actually play with the formularies, but it is true in Part B and Part A equivalents in Medicare Advantage. And to me, that's a really big deterrent to people moving into Medicare Advantage.
One thing I'd add to that is something we also wrote in the book that's still an issue, which is, the push for high deductible health plans doesn't have to end at 65. So basically the high deductible health plans don't exist really other than a medical savings account plan design inside of the Medicare program. And they have a fair number of restrictions in terms of what they can actually be used to do. Now that's, again, like many things in health policy, an artifact of history from when MMA created the high deductible health plans, really the HSA design, but the MSAs came out of the Balanced Budget Act of 1997. So there really needs to be a better harmonization of that. I know that sometimes it's politically charged because the thought is seniors can't manage these high deductible health plans. I think that's a false assumption in a lot of ways. There's lots of baby boomers that aged into Medicare that have high deductible health plans that sort of reach out to me or talk to the doctor, say like, hey, now what do I do with this as I'm transitioning in? And they've actually gotten used to using this as a vehicle to do something that could actually help, harmonize that benefit a little better.
So if I'm hearing you guys correctly, it sounds like you would be in favor of Medicare Advantage for all versus Medicare for all in some ways. Is that correct?
I'll say this so Steve doesn't have to have it on the record, but we have joked about that. It says, we agree completely with Bernie Sanders, except one word. And that one word is to change Medicare for all into Medicare Advantage for all. And I think actually it's if you really want universal insurance that's really universal, my favorite of all approach for that would be to have basically a universal voucher. Now this goes back in many ways to my graduate training at the University of Chicago, Steve.
Which is in Illinois.
It's in Illinois, but it's not the University of Illinois. One of my professors there was Milton Friedman, who was one of the premier economists and one of the very first of winning the Nobel Prize in economics. I had 2 courses in macro from Milton Friedman, and I'm not a macroeconomist, I forgot it all. But he was a big advocate, instead of having all the income subsidy programs, of basically giving income vouchers to people on the grounds that if you let them choose what they want to do, they'll be happier for the same amount of money and better off than if you give them food stamps and housing subsidies and that. And it's exactly the same concept in Medicare Advantage for all. It's exactly the same idea.
And one thing I'll add to that, and I think it fits what we talk about in the book, is that, you know, all options would be on the table if you did something like a Medicare Advantage for all. So the high deductible health plan with the HSA would be there. It's definitely going to be priced cheaper, but it could also be the highly restrictive PPO design, which is not that different than a Medicaid design that actually is offered by the same types of national Medicaid providers, Centene and Molina, namely. I mean, those things definitely come in at lower premium price points, and people, you know, can make that trade-off decision. I mean, one of the things that's sort of sobering is that if you just took all the federal dollars that go into healthcare today for benefits writ large, including even things that sort of go over into the Department of Defense of TRICARE and the Federal Health Employee Program, and you just wrapped it all up and made that into a voucherized system, there's an interesting question about how far could you get? Could you effectively cover the entire population with either the equivalent of essentially a Centene type of product that's coordinated, or a high deductible health plan with a lot, with all those things that we're talking about that would be nice for secondary prevention to be covered? I actually think, just in the back of my mind, for having done these micro simulations for now nearly 2 decades, I think that actually it nearly would be a wash. There may be political opposition on both sides, but maybe because there's opposition on both sides, there's actually an opportunity for compromise.
I have one more thing I want to say about Medicare Advantage plans. I view the choice of that versus standard Medicare A and B as a kind of a rationality test, my friends. A lot of them buy, you know, they're in standard Medicare A, B, and then they, of course, buy a Part D drug plan, and then they buy a Medigap plan, which covers all the holes in the financial coverage of Medicare A and B. Many of them are paying more in premiums out of pocket than the maximum risk they'd have under a high deductible plan. And so they're losing money for sure by staying in this archaic, bolt together system we have. And so I just tell my friends, that's a stupidity test. If you're still in Medicare AB and you're buying the most generous Medigap plan you can find, you need to go back to grade school and start doing arithmetic again.
So we received one comment that health plans would love to have Medicare eliminated. It sounds like there might be another question from somebody on the line. Jessica, is there another question that just came in?
Sorry, no, it was just that comment.
Okay, thanks. So feel free for everyone on the line to ask any questions, and we'll make sure that we can get to as many of them as possible. So now let's talk about some health policy changes that would affect the entire population. So maybe secondary prevention, for example, which I know is something that you both have spoke a lot about. Can you talk a little bit about which policy changes you think would deliver the greatest value to society?
There's so many.
Where do we start?
Yeah, like, I mean, I'll throw 2 out, and I'll double up on price transparency. I do think it could be transformative if delivered properly, but there's a lot of lift that has to go on. So just to be clear, there is a rule that'll be coming, or rule that has come out from the federal government, basically saying that private insurers must put onto flat files, that is an ASCII file, a text file, all of their prices negotiated with physicians in January 1 of 2022, not physicians, all medical providers. And that is a parts list, if you will, of the entire healthcare system. A lot of people are saying, like, for, you know, patients won't know what to do with that. That's crazy. I probably expect that to be the case, but I think app developers will know exactly what to do with at least the creative ones. And my hope is that what Chuck talked about with my chart would basically get fused together with essentially what comes with the price transparency app, so that effectively you basically end up with essentially the equivalent of a Travelocity for healthcare, or a Hotwire, or actually in a recent thing that was recorded in the LA Times, like an Amazon effect for this. Because if you actually combine, you know why you're looking, and some of that analytics gets to go into telling you what you're shopping for and the different medical procedures, that actually reduces the search quite a bit for you potentially if you have that algorithm run. And then potentially you can have providers post their prices, particularly if you're living in a more of a high deductible world. I think that trifecta of having that's why when we sort of talked about this chat saying, is it the first or last call? I think it's the first call for consumer-driven health plans, or the idea, or healthcare, because we finally have the fundamentals that could actually maybe make some of it happen. Necessary conditions, but probably not sufficient. I think the entrepreneurs need to make the sufficient conditions.
Right. Steve makes a very important point here, and in some sense, what we're thinking about is heavily driven by the internet and information technology. And it will make possible for consumers to be intelligent consumers, in ways that are just impossible before, by combining data and getting the shopping bots that go figure out where you are, or forget where you are. Do you want to go to the Mayo Clinic in Orlando, or the other Rochester, Minnesota? So that's all. Now, there's another part about this that, Bianca, that I'm going to toss onto the table in terms of improving health of the population in a very unexpected way. This isn't in the book that Steve and I wrote. It's in a prior book I wrote in 2010 called 8 Questions You Can Ask About Our Healthcare System, Even If the Answers Make You Sick. Okay. Now, there's a whole chapter in there that says the biggest public health hazard to us is our K through 12 educational system. And, Steve and I know from teaching in college that students from foreign countries are vastly better prepared in many ways than American students, particularly in math and science. But our K through 12 system is disastrously bad in these areas, and it is extraordinarily racist in its structure, through segregation, of geographic segregation and school system segregation. Now, the reason I say this is a public health hazard is, if you look at the data, and this goes for every kind of a health habit people have that reduces their health, smoking, there's a huge education gradient. So if you look at people that are not completed high school, like a third of them smoke. If you go to people that have completed college and graduate school, like 2 or 3% of them smoke. And it's a very steep educational gradient. That's also true for exercise and obesity, the same gradient shows. It's also true for excessive alcohol use, the same gradient shows. And it's even true for things like breastfeeding for mothers, which greatly improves the health outcomes of their children. And so if we could actually improve the retention of our school systems, the health of the public would improve dramatically over time. And it's very counterintuitive, but our K through 12 system may be the biggest public health hazard in our system.
There's a couple of questions that have come in around the transparency topic. So this comes from Rep. Jen Schultz, and she asks, what exactly are providers required to report in terms of charges, what's reimbursed, and are providers reporting charges based on the payer average charges?
That's a great question, and also a reminder for the chat is probably we're going to go off the record after this one, I think. And great to see you, Jen, by the way, at least virtually. The short answer is that there are 2 separate rules that came out by the federal government. One of them actually relates to hospital price transparency, and that one is currently in effect. The Wall Street Journal has had articles about that, profiling what hospitals are in compliance or not. The hospitals actually have to put in whatever their negotiated rates are with the different insurance companies that are there. It's incumbent upon them to do that, or else they pay a fine. There's several articles that have pointed out that several of them are not doing that at all and just want to pay the fine and be done with it. That's not the rule I'm talking The rule that I'm talking about is actually the one that comes out on 2022, which it doesn't require the providers to do anything. It's entirely incumbent upon the insurers. That's the big difference. For the insurers to disclose basically their negotiated price list with all of the providers that they have under contract. And that will probably vary depending upon the benefit design that they actually have. So the actual, one thing I did do when I was in the administration was more or less write down the exact variables that I know the insurers have that are available on their data sets essentially to disclose on those flat files. And furthermore, they have to disclose them on a monthly basis. The rationale for that is that there's an economic argument that there potentially is a problem for price increases to come along if these data is put out there. And one issue is that there could be hospitals or different health systems that might coordinate their prices. That's effectively price fixing. And so that could be an antitrust violation. That's very hard to prove, actually, in terms of getting the discovery data that kind of do it well. That's why we wanted to have it come out monthly, because it'd be pretty obvious if you start seeing a bunch of folks do this in coordination based on their prior history.
Thanks, Steve. So, yes.
This implicit coordination is a key issue in this. The little town where I lived in California before I moved back to Rochester had 2 gas stations. And every time there was a nearby holiday, the nearby Sea Ranch, which is a great big weekend community for San Francisco, on the weekends, these 2 gas stations would jack up their prices. And then when the weekend would come, and they always coordinated, they moved the prices in perfect synchrony. And I think they just had a, one of them said, you post your price and I'll match it. Or one of them was always a cent below it, but they moved in perfect lockstep. It was clear to me that they were coordinating, and the announced price was helping that coordination. So that is a concern about that. Somebody posts the price and everybody else says, okay, I'll do that. That's fine.
So we have a few more questions, I guess. Why don't we we're going to answer these questions for those that are on the line, but why don't we close the recording part of this, and just to say thank you to Chuck for that and Brianna, but then for those, please stay on the line.